Welcome to the Mindful Healers podcast with Dr. Jessie Mahoney.
And Dr. Ni-Cheng Liang.
We are physicians and leaders who are also trained in coaching, yoga, mindfulness, and integrative medicine.
We are also mothers, spouses, sisters, daughters, aunts, and friends.
In this podcast, we share candid, heart-centered, loving, science-based, thoughtful, and often fun conversations about the challenges life throws at us.
With our collective experience of over 30 years in physician and personal wellness, we reflect and offer pearls of wisdom for navigating life's challenges with more ease.
From parenting, marriages, money scarcity, cancer survivorship, uncertainty, challenges in practicing medicine, we cover it all.
We invite you to refresh your perspective and empower yourself with mindset, mindfulness, and other well-being tools that actually work. A quick reminder that nothing in our podcast is medical advice.
Welcome. Today, we're going to talk about how to partner with leadership and potentially the C-suite on wellness. And we have a special guest, Dr. Brooke Buckley, who is an old friend of mine, who is also in leadership. And she's going to bring us the leadership business school higher up C-suite perspective, and I will be your wellness pediatrician perspective. And we were going to have a conversation. And the conversation was inspired because Brooke gave a lovely talk at Brave Enough this year about this idea of how do you partner to improve our collective health and well-being in medicine. And it brought up so many ideas that we had in common as we took our Uber back to the airport that I said, we're going to record this podcast. So many months later, here we are. And so let's jump right in. And I'm wondering if you would just introduce yourself and share whatever parts of your life you want to share with us before we launch into our conversation.
Thanks, Jessie. It's really an honor to be able to have this conversation together and to explore that partnership between physicians and administration on wellness in this kind of friendly conversation. We were chatting before we started recording that so often this gets to be such an intense conversation that sort of examining it from the 30,000 foot view is a real opportunity. So I am a general surgeon by training and practiced for 5 years in a very small town in a 4-person group. And subsequently, that group, through a lot of complexity with administration, fell apart. And I ended up being an acute care surgeon for 6 years. Ended up leading that group largely out of frustration because our interface with the hospital and with administration was so difficult. So I kept trying to solve these problems as we often do. And certainly as surgeons, we try to solve things and kept running into barriers and different boundaries. And so through that, I ended up getting what I now understand as operational awareness, or the ability to navigate the rules and regulations of a hospital from a physician running a physician group perspective. And that then led to getting an MBA to have better language and tools around what is this all about. And I've been a chief medical officer now in 2 different hospitals, in a small independent rural hospital, and now in the Henry Ford Health System in Detroit, to really kind of understand these interfaces in a broader way. So really looking forward to diving in.
Yeah. So I'm going to start off with something a little bit negative, but I think it's really helpful as we frame our conversation. Right before we started recording, and we said we should really be recording this, was my thought that wellness, which seems like this lovely topic, is actually full of a lot of anger for many people, and frustration and blaming. And we mentioned a little bit of all these intense emotions: victimhood, grief, whose job is it? And this sort of, it's almost a area of conflict. And I realize in this moment that, I spent 17 years working on wellness before I switched to doing what I do now full time, which is wellness, but doing it on my own. And one of the reasons is because I do not like conflict. And as wellness should have been a non-conflict leadership role, it was filled with intense conflict, which is interesting. And when you're sort of going against the grain of a culture, it takes tremendous amount of energy and actually leads to a lot of burnout. And so as we're talking about wellness and how many of us feel so strongly, and we feel like it's our mission and our job in life to fix and change things that are totally out of control, it leads to a lot of this negative energy. So I just want to call that out at the outset. And I think my hope in having this conversation is to lessen a bit of that and bring more peace and hope and collaboration and partnership to the conversation.
Absolutely.
So let's start with this concept of how to navigate the system. And one of the things we discussed was this idea that we have to navigate the system as it is, rather than how we think it should be. What are your thoughts on that?
As you're talking, I'm remembering Cy Wakeman sharing with us the reality-based leadership work that she does, and the drama that ensues when we try to live in a space that isn't the reality, but is more what we've built in our heads. And I think, and actually recently wrote a paper on the margins in medicine, meaning that our profession and our identity is so strongly built on leaning in, doing that extra thing, saving a life. And so often that means self-sacrifice. And we're trained that way in residency, even currently trained that way in residency, right? There's a currency around I can self-sacrifice more than you can, different in different specialties, but it exists in all of medicine. And I think 30, 40 years ago, when our income and our lifestyle and the technology and the pressures of malpractice were so different than it is now, that maybe that margin to do volunteerism, if you will, but that space to give freely of yourself was compensated in some way by society honoring you, by family understanding, by not getting sued, by an abundance of money compared to what it costs to live. And that margin has just gotten so small that it's largely non-existent. And so it does drive a certain amount of, it's not fair that I've become this person that leans in so hard to save your life. And yet it doesn't appear that anybody is even giving me an atta girl. They're just like, good luck, keep going. And so really coming to terms with what our reality is in our individual practice environment, our town, our nation, getting clear on what we can and can't control and manage is probably really an important first step to this conversation.
And we often talk about whose job is it? And there's a lot of name calling about whose job it is. And so recognizing, I've said this recently, the system is extremely complicated and extremely complex, and it's a many layered and highly emotionally charged topic. And I think that just that recognition of we can't fix it and it's not our job to fix it, but where is our lane and where would we like to be and what difference might we like to make? And even if you happen to be a chief wellness officer, where focusing on what's in your control, which is something that in medicine, especially, I find people in surgery and ER and those professions that there the focus is on controlling things that are out of your control. So you get to wellness and you try to do the same thing. And so narrowing the conversation, I think, is really part of the strategy to what's in your control and what do you want to work on and what do you have capacity to take on.
And even as you're saying that, realizing that wellness means so many things to so many people, and even by specialty, what a pediatrician is looking for versus what a surgeon or an ED doc is looking for may be gigantically diverse, even within a department, but certainly across a specialty. So a chief wellness officer has this scope that is absolutely gigantic, trying to solve with individual projects or cultural changes. And so again, just taking that moment to recognize that we are trying to eat an entire elephant and want it done yesterday.
Well, and that's our urgency bias. That makes me think also we're going to talk a bit about language going forward, but this word wellness, which I think is a difficult word to use for what we're trying to do. And so I think we're married to it now in the system, so we have to continue using it. But I think many people feel like, well, do we get to be well? Are we supposed to just enjoy this job? Because I really don't enjoy this job and I'm not well. And so therefore they're not doing their job. And yet maybe it's more about sustainability or feeling alive in your practice. I can't think of the right word there, but not so much are we well, but looking at it in other realms might be a less frustrating and more forward moving conversation.
No, absolutely. I find myself often saying that we need to look as administrators and as leaders for opportunities where we can come to work as a human and be able to perform our job without insult to our, mental wellness and our psychological security. And so I think that's what I'm kind of hearing you say is I don't necessarily need to come to work with bubblegum and popcorn and unicorn and, be skipping down the halls. That's probably not a reasonable expectation. But to be able to come to work and not leave less healthy than I entered is a reasonable expectation, to not be physically injured, to not be emotionally injured at work. And I think sadly, the pendulum is to the place where most of us expect to be mentally and psychologically harmed every time we walk through the door. And that it's not sustainable and it's not accepted in most industries as we talk about it. And so for healers to expect to be harmed in their work, we know something's wrong.
Yeah. Well, and that, I have two thoughts on that. One is just, I often talk about how we were raised in medicine, and we were sort of raised that when it does harm to you, it's more valiant and it means you're a better doctor. And that the expectation isn't that you should be intact at the end. It certainly wasn't during our training. And so as you said that, my brain just went to, yes, that's like the inherent problem is this cultural idea that that would be expected or would be okay. And yet, as you mentioned, for no other industry that I'm aware of is that actually accepted and okay. And so part of it's changing that conversation. And what if that were the conversation? What if that were the language that, we've talked a bit, you and I, about humanism in medicine. And what if physicians weren't heroes, but they were humans and they had human capabilities and we treated them as we would treat any human? Or I often like to say physicians as well. So we're going to care for the patients, but we're also going to care for those caring for the patients, and that we're all in this together. And that would be a different language. So I wonder if the language around wellness were really about doing no harm and making medicine a safe place to practice and a safe career from a health and emotional and physical health standpoint. I'm a bit tender in that one of my colleagues from a long way back actually committed suicide this month. And I don't know the details, but based on what I do know, I'm sure it has something to do with being a physician and a physician wellness standpoint. And I think just recognizing that that is all too commonplace. And so this is, I think you're right to say, it's like a do no harm conversation. And could we start there? And that, in my mind, is a strategic way to work with leadership, because they don't want harm and and nobody wants that. Like, we are aligned in that.
No, absolutely. And I've lost, sadly, 3 colleagues in my career. And I think all of us have that story. And it's so sad and it's so diverse in the way that it presents. So hard to get our arms around and becoming kind of an accepted part of our path, right? That we all intersect somewhere. But I think you're leading to a place to really pivot around the language, right? Getting on the same words that we use, but also the acknowledgement. And I think from an administrative standpoint, I can say that I live this, that we all know in our brains that resources are limited. There aren't enough beds, there aren't enough nurses, there isn't enough money, there aren't enough hours on the MRI, you name it. And so it's very convenient to not recognize the depth of need, because if you look in the eyes of the depth of need, you have to then figure out how to get the resources to fill that hole. And so being able to merge wellness language, mental health language, and corporate language, policy, process, structure, and get those two to intertwine can then really help us to almost get a menu of what can I affect, what are the levers I have to affect it, and what type of budget do I need to make this happen. I don't think, for instance, that most hospitals want to not pay doctors for call, but most hospitals can't afford to pay doctors for call. And so pretending like that isn't an issue or obscuring what we're really talking about when I'm saying I'm too exhausted and I don't feel safe, and an administrator says, well, I can't pay you, so just go because the rules say you have to. It breaks down and it gets us to the next day, but it doesn't at all even start to solve the problem, which is I'm perceiving there's human harm for my patients. I know there's human harm for myself. This isn't sustainable. And what are we actually doing to solve something practical in this space? And those harder conversations as we get to sort of the practical pieces is if in fact my hospital doesn't take call for, let's say, general surgery, then those patients have to get in some form of a transport to another hospital where the doctors and the staff are equally exhausted. And that transport time may change the outcome of their care. And in Detroit, that may not be super consequential. When I worked on the eastern shore of Maryland and the bridge was out and the wind was too high and the helicopters couldn't fly, it was life or death for certain OB patients and general surgery patients if we couldn't care for them in our hospital. So we carry that moral burden as well as providers. I know if I don't show up, even though it's for free and in my own harm, somebody else may not survive. And we need to figure out how to, I loved one of my colleagues used to say that at the bedside, I am doctoring. In the administrator's office or in the negotiation room, I'm a business person. And that our opportunity to separate those two elements of ourself and our work is really, really important, because so often we are bedside physicians in the administrator's office. And the anecdotes about how you didn't sleep last night are totally irrelevant to a structural conversation about, can I pay you for call? It fuels the desire to help, but it doesn't help us get to the solution. And so separating those two and being able to see those as two separate things is hugely important to moving these conversations along.
So as we bring to those conversations, I'm thinking what helps when, as a wellness person who also might be taking call and being too tired, like how do we have that conversation and how do we bridge that gap? How do we go in as someone who is a bedside physician, and maybe you don't want to do that. Maybe you want to go to your wellness lead and have them do it. But if for those who are listening who happen to be a wellness lead, I think understanding this sort of strategy or approach is really helpful. And so the thoughts that came to my mind were, one, being strategic or deliberate. And I think that's partly what we talk about, and potentially things that are in our control or could be in our control, I might say. And I often talk about the energy you bring to the conversation, because we talked initially, if we come in fighting or in conflict or that we're on different teams, that of course doesn't really help. And then and we sometimes come in as, it's not fair, you mentioned, or I'm a victim, or you mentioned even this idea of grieving the way it's supposed to be. So we'll talk a little bit about that as well. And then the third piece, I think, is the language that we use. How can we collaborate on how are we in relationship coaching? I often talk about how is your partner just like you? And my thought is, how are the administrators just like you? Like, where are you aligned and where do you both want the same things? And then I often think, I did both wellness leadership and department leadership. And for me, it was like, well, how can I frame this in a way that they're going to be happy that they get something that they want and I get what I want? knowing that sort of what we all want is ultimately a healthy functioning department and healthy patients who get good care. And so it's really sort of thinking about it in this strategic way rather than a woe is me frustrated way. And so I thought maybe putting it in those three pieces or buckets would be helpful. So if the first one is strategy and being deliberate with the energy that you bring and maybe the approach, do you have other thoughts of pieces of wisdom there?
Yeah, what comes to mind is owning what I can control and partnering in what I can't control. And so there's so much in a department, in a medical staff, where we have our bylaws, we have our rules and regulations. And for better or for worse, physicians have a bit of a reputation for playing both sides of that aisle, right? Like the docs that were wearing their masks under their noses during COVID when any other employee would have lost their job. Physicians typically don't. Physicians typically get this extra citizen status. And so I get why in some ways often it's a bit of again a bit of a trauma response that I'm so broken and so harmed that I don't have to do these normal things like park in a single parking space because I'm and so really kind of processing that grief or processing the why that we feel we need to be outside the rules, but then truly strategically taking a look at what rules do we have for ourselves. Do they make sense? Are we following them? Because if my house isn't in order, to ask somebody else to put their house in order on my behalf to compensate for what I haven't managed it's a tall ask, right? That's in our own lives. If I show up to the grocery store without money and expect to get paid, but I, left my wallet on the counter, and expect to walk out with groceries, it's probably not going to work. And we've kind of accepted that those rules work that way. But oftentimes, as docs, I don't want to have to follow the policies, but I want you to make this other policy that advantages me. And why won't you do that for me? So,
Okay. Yeah. And tell me a bit about the energy that you think is helpful to bring to those conversations. In that I had mentioned not bringing a victimhood energy or woe is me energy, and you had mentioned this concept of grieving, which I found really a powerful way of thinking about it.
yeah, for me, and having, traveled this process from full bedside clinician to full administrative support, the dream of what we thought it was to be a doctor, whatever that is that we carry around, the romantic notions of that, and really taking a full assessment of what is our reality, our current practice scenario, and recognizing that to pivot from where you want to be to where you are probably is a grief process. There's probably a certain, death of a dream that we have to move through all those stages. And so if you think about it in that way, that anger stage of grief, I feel like we are stuck. And I understand, I'm wholeheartedly towards why we are stuck, but it's something that comes to mind often. And when I first became a CMO, I always used to have my starter slide as disclosures say that I had moved to the dark side. And I had a friend say to me, don't do that. Don't say that. Don't give energy to that space. Like, having been a physician and now being a physician administrator, you have that intimacy, that caring for people, that self-sacrifice gene, that DNA. Like, we share that lineage. We were talking about the lineage of people we went to med school with, right? Like, you carry that experience through your entire life. And so for us to bring an energy where you are administration and I am a doctor, especially with physician administrators, you're already setting this up for an us and them. And so that's again, open-heartedness of, I understand that you are a physician sitting in this seat, trying to create a bridge from the practice of medicine to the practice of healthcare. And how can we work together? What are the common ground? It is, I think, really important. And it takes a bigger self to find that energy, right? It takes a lot of kind of holding curiosity in space to not be so angry and so frustrated. And I truly believe about anybody that works in healthcare, nobody's coming to work trying to hurt people, hurt doctors, cause problems, and destroy communities. And it is such a broken system that our influence is so small that we've got to figure out how to amplify it. And I think really coming with that kind of empathy towards each other is a real important first step.
And having doctors in administration is actually helpful. It's interesting. You are not the first person who said I've gone to the dark side. And I'm like, whoa, no, no, no. Like, you're there as a physician who, imagine if there wasn't a physician in that role and there was someone who didn't understand any of it. So we actually need physicians who are there. I always say one of the things I think is so helpful about coaching is when doctors are healthy and have more clarity of thinking and understand their tendencies and how they were trained, they can be the best advocates for healthcare. And we can't advocate for ourselves from a victimhood, anger, frustrated space. We can't do it. And when we're unhealthy and burnt out, we don't get what we want because we don't advocate well. And so taking good care of yourself and then taking on some of these jobs, it's not for everyone and it's not our job. But if it's something that interests you, it's certainly not the dark side. It's actually how amazing to have someone there who does understand. And it's those physicians in administration are actually able to maybe be the translators of the different language, if that makes sense.
True. And I think so often too, when we hear this, don't be the victim, sometimes we hear you're not allowed to feel like a victim.
Yeah.
And for me anyway, it's that victimhood, that hurt, that pain, that grief. Like, I'm going to sit in the corner and cry at certain times. But when I am putting on my hat to advocate for wellness of the physician workforce, I am showing up as my best self in that context around being a bridge maker, because I actually genuinely want this to work. And so you have to figure out how to sort of compartmentalize. And a friend puts it, don't put the patient in the middle. At the bedside is the wrong place to be complaining about call schedules. That it has no place in front of a patient. Anesthesia, frustrated about epidurals, has no place in front of a patient. However, it absolutely needs to go to an administrator or a leader immediately when appropriate to figure out how to create a better process to create better health and safety for everyone. And I think trying to find a way to see clearly and how to compartmentalize those for ourselves is the path to wellness, and the path to the policies and processes that create better overall structural health for all of us.
And I do think one thing you said, I think it needs to go to administration and it needs to go fairly in the moment. I think many times, not in the moment when you're angry, but in the moment when you've had a nap and you've caught your breath and you've repleted yourself and you can go in strategically and deliberately. But that oftentimes we either go in the moment when we're ready to blow, or we don't say anything, and then it's sort of a nebulous conversation. So I do think the specifics are really, really important. The other thing you mentioned was building a bridge, and I think that's the perfect pivot to the language conversation, because engineers build bridges, and they build bridges using a lot of technical terms that I don't understand because I'm not an engineer. But it strikes me as very similar because the administrators are speaking one language and the physicians are speaking another language. And so one of the things that I found most helpful as a wellness leader was to put things in terms of cost and put things in terms of retention and think about, well, what do they need? What, if it increases productivity, they're all ears. If it decreases errors or decreases, so improves quality of care or decreases cost of care, all ears. And so what other language do you think is helpful in the translation?
Yep. So a couple things. One is we can't all be masters of everything. And I've often said it is not practical nor appropriate for every doctor to get an MPH, a PhD, a JD, and an MBA. Like that can't be the answer. So actually learning all of the language of business is not appropriate. However, there are those of us that have gone to MBA school or other graduate programs to learn that language. And so partnering, finding translators. And so that could even be a physician with a finance person. Find a finance person who talks like a human, right? Who isn't so quanty that they can't use words, and figure out how to get them to translate. So build those models, if you will, build those scenarios of a future and ask someone in one of those disciplines. And it could be your CMO, it could be your finance people, it could be your chief nurse. Like, how would we build a program with your language and my language together that resonates for the other needs? And the other piece sort of scoped out from that a little bit. So partnership for one, but it also has become very clear to me that hospitals and hospital systems are responsible for generations of people, for the next 50, 100 years of this community. We are trying to make decisions that will keep this community safe, the children safe, the public works safe, right? And move this community along in a healthier way. As a physician, that is part of my mission, but we also have a much more focused, this patient, this moment, this episode, this family, my career space, so 30 to 40 years. But truly, the day I retire, it's somebody else's problem what happens to these people and families. And so being sensitive to that interface, where I would love to pay you for a call, but if I bankrupt the hospital this year, I have no trauma program next year. And all of these people struggle with their ability to maintain employment and to live in this town and to fuel the church and the schools. And so trying to figure out how to cross that path from the one life to a community and a generational perspective also, I think, really helps to cross that bridge. So putting it into language of finance and structure and business through partnership with people who technically know the language, and looking across generations in a more public health kind of perspective in terms of this discrete ask that, yes, it will help me today, but it will help the hospital system support the community over time.
Yeah, and that reminds me that much of this is not about you. So when they say, well, we can't pay you for call, it's not because they don't value you, which is the interpretation in our brain. It's often about a bigger calling. And not that it's our job to sacrifice for that bigger calling, but to recognize that there's all these pieces in there that are largely out of our control and largely societal and cultural, that we can sort of choose where's the crack, where's the light, where can we meet in the middle and make some change. And I think even just opting out of that story, that any decision they make is about valuing you, because when you say, well, they can't pay you for call because the hospital needs to keep functioning, many individual physicians get very upset. And it's true that they should be paid, right? We all agree on that. And so the question is, how do we get there? And it's going to be a long, evolving process. I do think it's important to ask, and it's important to have the conversations, even when the answer can't happen. I used to say that it was my job to bring things up, because 3 to 5 years from now, they would be possible. But if I didn't bring them up, the clock wouldn't start ticking. That was in my brain. I used to get really upset when they would say no initially, but then, and really frustrated when 3 to 5 years later they would happen. I was like, why didn't they listen to me? Well, that's actually the time course, and it wasn't about me at all. And so I think bringing up these conversations in a strategic, thoughtful way and hearing all of the different voices gets things moving, if that makes sense.
No, absolutely. And I think we experience this, in our day-to-day life. And it's just much harder and more personal because we are so morally injured, or you're, burned out, your word of choice on that. And so it feels so much deeper. But I often, at least as an administrator myself, I try to give a lot of context and give a lot of tools to my physician colleagues around the why. So yes, you're giving me a $15,000 ask, and it seems totally reasonable to get new mattresses in the anesthesia call room. And I have $2.5 million of $15,000 asks from physicians, up against nurses asking for, lifts and duress buttons and, things that have a lot of importance off the cuff as well. And so help me to learn how to prioritize these things. And to your point, probably 3 years from now, that ask gets to the top, and that's how
Right.
long it takes.
Yeah.
I did a lot with the legislative committees through the state medical societies, and we often would bring bills 2, 3, 5, 10 years before those bills, whether it's seatbelts or helmet laws or those kinds of things, become real, because it takes that long to socialize and to get people to normalize and get through that change curve around this is a good thing. And on scope of practice, physicians tend to love that it takes 2, 3, 5, 10 years for something to gain legs. But when it's, I need something fixed in my direct environment, it's absolutely aggravating.
Yeah. Yeah. Well, and so part of this comes to just being patient, which is one of those mindfulness tenets, which we don't really want to be because it feels like a crisis and we shouldn't be patient in a crisis. But my personal thought is if you come in with this patience and more equanimity, that's actually an effective advocating strategy. And recognizing that, these are the things that are important and maybe seeing which one they can do, for example, or which part of one they can do. Then everyone feels like you're making progress and you're not butting heads, if that makes sense. The other thing I think is it's very hard to advocate effectively when we're exhausted and depleted. And so many of us are approaching the calm room mattress from that perspective. I'm not sleeping and you are depleted. And so my thought would be take a nap before you have the conversation, or have these conversations, schedule the meeting for when you get back from vacation, when you can actually come in and be strategic and thoughtful, and maybe have done your research. That's the other thing. So how much are mattresses, or where, which room is the most important? Those kinds of things I think can be seem like they're not your job and can make it easier. I like to make it easy for people to help you do the right thing. And that can be a really helpful strategy as well.
Totally. And what you bring up for me is a couple things. One, I think in anything, if you can give somebody the self-addressed stamped envelope, you're much more likely to get a response, right? And so the more tidy you can package the ask, the more clear you are on what you need and why, the more likely you are to get a positive result. Simultaneously, because we have such agency as physicians, all see ourselves as leaders. And so if I'm in the ED and my wow isn't working, and the computer, I feel very entitled to storm right up to the president's office with my computer to explain why I need a new one. Whereas there are processes in place for any of these types of asks, and probably the computer's been a little bit funky for a while. And, constantly, I know many hospital systems use that rad logic system of reporting, and physicians almost universally resist reporting because it takes too long, it's annoying,
Me.
it's for somebody else, right? And if we don't report until it's a crisis, and then we go into the med staff meeting once a quarter and raise our hand and say, well, all the chairs are ripped and, administration hates us. I often, as an administrator, will say, we will work on that now. And it would have been really incredible if 3 months ago, 6 months ago, you would have used your leadership structure through your medical executive committee and your chairs, who literally meet at least monthly. And any one of the 500 people in this room would have raised that point as it was becoming a problem. Now it's a crisis, and I understand why people are upset. And it's really hard to be crisis managing all the time on behalf of physicians. And that's we really have an opportunity to dig into our leadership structures and understand that better, that if I'm a clinician and that's my full job description, that I probably have a department leader or an elected chair through medical executive committee and medical staff that represents me at some level in the organization. And it's actually tools them up to be better leaders if I bring to them my frustrations early. But it also creates a lot more clarity and precision in terms of getting what you want, because the interface from the highest levels of the organization to medicine isn't 85 angry doctors, but it's the chair who can speak very clearly and rank order what is necessary. Right? It just drives a lot more clarity. And we are pretty famous as a profession for kind of scattering that power all over the place. And it really is harmful to us because the ask is so muddy.
That is such an important point. And I am curious, how do we find out? Now, physicians don't have any time. So how do we find out what the structures are or what's the right path? Is it sort of thinking of a streamlined approach? Maybe as a former department chief, maybe that person explains it once a year. Or says, when you have these concerns, come to me and I will filter them. But I do think that physicians are reactive, one, because they're depleted, two, because we are urgent, always. We have an urgency bias. And then, and we're depleted and frustrated, but we also don't necessarily know the path. And we don't necessarily have time to know the path, if I'm being honest. And so, and maybe many of us resist also all of these hierarchical systems, and we train so long that why should we have to go through them? But if that is the smoothest path to the answer, how do we make more people aware of that?
Yeah, no, and I think it's one of these unsolvable problems because physicians are physicians, and I think it's part of who we are. And I can't expect you one moment to save a life with a knife in the middle of the night with a stranger, and in the next moment, get into the weeds of bureaucracy, right? Like that's a lot to ask of a single human. And to whatever sense that we can have awareness and recognition and create that space between, stimulus and response, we, by definition, through Joint Commission, all have medical staffs, and different in next podcast around employed and private, but there is a structure that exists for each of us within a working environment, even if you're the junior partner with a senior partner. And so the onus is on us to ask to a certain extent, but we really have opportunity around orientation and leadership development. And so I think if you are accepting a leadership position, or if you are entertaining the idea of accepting a leadership position, really thinking about what have I done to acknowledge leadership as a separate specialty, what skills, what tools, right? We never would go to a new procedure without having learned about that procedure, but we go into leadership with the assumption, with the bias that I'm a leader because I'm a doctor. And to a certain extent, people grant you that because of your title. But our actual ability to lead, I mean, it's really hard when you're in a room as a physician administrator with other non-physician administrators, and a doc comes in and acts like a complete baby, screaming and yelling and whining, not using the process, expecting to be treated totally differently, expecting not to have any consequences of their behavior. And then my job is to manage the medical staff around. That's actually the expectation of all of the doctors, is that I can act completely outside of society. And everybody's supposed to continue to embrace me because I have this special hard-earned skill set. And I'm not saying that doctors don't deserve a special place in society, in the world, because we've worked incredibly hard and do things at our own harm in a way that most other professions don't. However, we also, I think, have the opportunity for the personal responsibility and maturity and wellness, personal investment in our own wellness, to recognize that that's not actually who I want to show up as, that I want to show up as the professional that I want people to believe that I am. And that takes a bit of training, self-control, and reliance on others to, make that system work. So I think we can orient people better. I think the leaders can do better at leaning into almost rounds, right? Like, do you have anything that's going wrong? Is there anything that I don't know about your daily work that I could do to advocate to administration because the chairs and the computers are wonky? I think that we could do better with orientation. We could do better in medical school, helping people to see those spaces. I used to take the surgery residents to the supply chain area and just feel like, these gauze don't end up in these buckets without Sally. Sally's job is to get it from the box to the bucket into the cart to get it to the OR. And so when you lose your mind in the OR and wasting supplies because they didn't come to you correctly, try to remember that Sally's down here doing the best that she can, and maybe a conversation around how do we do this better is an opportunity, right? And we're never going to get it perfect all the time, but I think the more space and grace we can give, and to your point, it comes from a place of being healthy ourselves, which truly, and I think this is probably, where we're headed next, is we're trying to bite off the entire profession, the entire healthcare in America, the entire world's health. I want to solve all of it. I have an urgency around all of it, and I should. And we drive ourselves crazy and we make ourselves less healthy and less able to function in that space. And so getting really clear on what can I tolerate, what can't I tolerate, what do I want to accomplish with my career, and what is outside of me, and then doing the absolute best that you can within that sphere of influence that is reasonable to choose, and letting the rest of it go. And it doesn't mean not interacting, not engaging, not being empathetic to, but it means I'm not curing cancer in my lifetime. I hope it gets cured. I will sit at any table where we can brainstorm on that, but I'm not carrying the burden that curing cancer is mine. And so I've changed jobs 4 times, and part of that was moving to a space that I felt had healthier structure for the way I wanted to live my life. I can also say, having changed jobs 4 times, that there is no perfect place, and sometimes hunkering down where you are and moving the levers that you can, and whether that's employed or private, whether that's call or not call, whether that's hospital-based versus an ambulatory practice. So many of us are really struggling with trying to do it all, right? Ambulatory, inpatient, in the adult sphere, the nursing homes, a little bit of concierge over there to make the ends meet. And that's another hard and sort of grieving process, but we cannot have everything. And the sooner that we can understand what is reasonable to try to have and to try to influence to keep me and myself and my family and my people happy, the better fighting chance we have to affect that area.
Yeah. So I think what I'm hearing is being mindful, pausing. You said space and grace, but literally giving yourself the space to be intentional and have agency over where you want to have your influence and where you can. And this acceptance that it isn't, people think it's better there. If I quit this job and I go there, it will be better. And then we find out that there has its own issues. And so from my perspective, so much of it is working on yourself. And that's not because you are the problem, but it's because we're working in a flawed healthcare system, in a flawed culture, in a flawed society, and that's probably going to be true forever. And so all we can do is sort of own how we show up and the contribution that we make. And actually choosing that smaller contribution, you may have a much more powerful impact. Maybe you only influence your one OR. Maybe you only influence your one department. And maybe you influence simply your patients. I think sometimes too, we all want to take it on because that's what we're supposed to do. And a good doctor would do that, when maybe a good doctor would take care of themselves and take care of their patients, and that would be okay.
Yeah, no, totally. And I think about, they call it in business school, the shadow of a leader. But we create this echo and this ripple around us based on our behavior. And so many of our colleagues are redefining what it means to be a physician, right? Going from bedside to more of a coaching or more of an educational platform that is still very much being a physician. Being an administrator, I believe, is still very much being a physician. You're setting structures and safety so that the process of healthcare and delivering healthcare is more functional. And so really kind of setting the foundation for what do we want our profession and the delivery of healthcare between doctors and patients to look like in the sphere that I can control. And I don't want it to be messy and underpaid and overworked and all these, rising violence and all these things. And I really don't want it to be the totally freaked out doctor yelling and screaming and throwing things, because I also haven't taken care of myself. And so if I can function in a space of calm and of kindness and of empathy, I take so many angry phone calls from docs. That's part of my job, is to absorb and hold space for how much grief and how much pain is going on in our profession. And then we convert from there to what can we actually do. And so I think that, if we can get our heads around that, showing up as the person that we want to be as a doctor in the best case scenario, gives us opportunity to start to move the system in that direction. And it's not going to be in our lifetime, but we need to be part of the migration to make it happen.
And that's really what's in our control, and our responsibility is ourselves. And so that strikes me as a perfect spot to end our conversation, really acknowledging that it's focusing on ourselves is the thing that we can do to be the most effective advocate, and show up strategically and intentionally and thoughtfully and act in ways that I like to say my future self would be proud of, most of the time. None of us are perfect. And that is really probably the most strategic way to effectively advocate. Any final thoughts that you want to add to that?
No, just thank you so much for the conversation. And I think, for any of us to continue challenging ourselves to stay curious, to look for opportunities for small solutions and incremental change, that relentless incrementalism, and really to look for the opportunity to lead like we want to be led. Because I think the change starts with us, as you have said. And sometimes as disappointing as that feels, once you really kind of lean into that, you realize how many lives you can affect in a positive way and how you can change your hospital and your communities based on that type of leadership. So
that's beautiful. And I often like to say we often don't want to be disappointed, so we disappoint ourselves. And so at least don't disappoint yourself, right? Like then
fair enough.
disappointed. And because every physician I know is an amazing human who can do amazing things, if we just stepped into our little piece, the difference we could make would be quite significant.
Absolutely.
Thank you so much for this conversation. It was a delight as always. And I love your, I'm going to call it special, unique perspective. That's something that many of us don't get to hear, that language and that perspective. And we're not the person who's receiving all the calls and who's navigating all of those different tensions. And when we become aware of that, it's really eye-opening and shifts our perspective. And I think our way of potentially influencing and leading to effective change. So I am very grateful that you are willing to share that, and grateful to have you stay a part of my life. And I will plan to see you for sure again in person.
Wonderful.
In the year ahead. Thanks so much.
Wonderful. Thank you. Take care, Jessie.
Thanks so much for joining us.
We encourage you to dive into the show notes for each episode for more learnings and resources.
We also invite you to take a listen to the many other Mindful Healers podcast episodes, and please share the podcast far and wide with colleagues, friends, and family.
If our message and approach resonate with you, we would love to work with you.
When you listen to a podcast, you consume information, but when you work with us, you can actually practice and change.
We offer coaching and mindfulness experiences, talks, workshops, retreats, and more. Connect with us at themindfulhealerspodcast.com.
The content of this podcast is not medical or life advice. We invite you to participate in the mindful moments we offer at the end of most of our podcasts, but please only do so safely.
Welcome to today's mindful moment. A moment of finding calm and channeling the energy of potentially a tree or a lighthouse or something steady in advance, potentially of a challenging meeting or a difficult conversation. Taking a moment to find your breath. Close eyes if it's safe to do so. Notice your sit bones on a chair or your feet on the floor. If your heart feels tense or angsty, bringing a hand to heart. If your thoughts are super spinny and it's safe to do so, put your head down, maybe in child's pose, maybe on a block on your desk. Notice what your body needs and where you can find centered, calm, steady, your inner strength, where you can connect to your intuition, your integrity, your authenticity. Then take a moment to slow down, reconnect with your breath, and connect with your calm inner wisdom. Groundedness. Perhaps sending your roots down like a tree and having a strong tree trunk. Standing tall, not reactive. That inner strength. Or being a lighthouse, knowing what you believe in, what is in integrity for you, and shining your light out as a message. Or choosing your own intention as you move forward. Perhaps you'd like to come into the conversation with an intention of connection or an intention of hope, or maybe open-minded, open-hearted, maybe simply open, maybe curious. Taking a moment to think about how you might like to enter a conversation. What energy would you like to bring? What energy would you bring if you were advocating rather than complaining? If you were partners rather than on opposite sides of a struggle? What energy would you bring if you knew that things would work out? If you knew there was a place in the middle that you could meet? Maybe it's the energy of trust. Trust that everything will work in the end. Maybe it's the energy of belief or possibility or opportunity. Taking a moment here to breathe and pause and connect with your inner knowing. Connect with your guiding light. Connect with the energy that feels most hopeful and optimistic and collaborative to you. Seal that energy behind your heart to take with you. Taking in another 3 deep breaths. Breathe in through your nose and out through your mouth. And twice more in through your nose and out through your mouth. And a last one in through your nose and out through your mouth. Taking a moment to reconnect to yourself, to find steady as you open eyes and bring your hands back to wherever you're comfortable. Taking a moment to transition and adapt to where you are in this moment. Thanks so much for practicing with me. We'll see you next week.